Hello, I am Dr. Samin Afzal Junejo from Hyderabad, Pakistan. In this video, I will show you the technique of closed chamber capsulorrhexis, which we usually perform by the help of a cystotome. And in every case, the needle cystotome is passed into the anterior chamber through surgical limbus, gray line. And we have already discussed many times the advantages of the use of surgical limbus. We do not make a full thickness corneal incision, and we do not take the advantage of the full thickness corneal incision while doing the capsulorrhexis. This is all a closed chamber capsulorrhexis in anti-clockwise direction, usually 5 to 5.5 millimeters in diameter. And as soon as we complete the rhexis, a regular round curvy linear rhexis, now you will see that as the rhexis is done and the cystotome needle is taken out, there will be a gush of aqueous through the cystotome port, which will push the anterior capsule towards the cystotome port, and the cystotome port is plugged from inside by the capsulorrhexis. In this way, anterior chamber is quite well formed. It is deep and intraocular pressure is very good, which accommodates the keratome to go for the two-step full thickness corneal incision. Again, I will show you another case where we have got the entry through gray line. We are using the insulin syringe needle as a cystotome, and in a formed and normal anterior chamber we are trying to create the round anterior capsulorrhexis. And as we are done with the capsulorrhexis, and when we remove the cystotome out, there will be a small gush of aqueous from inside the anterior chamber towards the cystotome port, which will immediately push the anterior capsule, and the anterior capsule will plug the cystotome port, and then there will be no more drainage of the aqueous from inside the eye. The anterior chamber is quite well formed. It is deep or adequate. Intraocular pressure is normal, and we can very comfortably, as you see, that there is a gush of aqueous which is coming out through the port, and that is the anterior capsule which is plugged, engaged into the cystotome port. In this video we can see very clearly that the triangular part of the anterior capsule is plugged up, and then we use the diamond knife 2.7 millimeter and gave a full thickness corneal incision very comfortably. This is another case. We just put the viscoelastic solution on the cornea, anterior surface of the cornea, to provide the hydration and the clarity of the media. And now we will use the needle cystotome through gray line, and we will again try to create a round rhexis in the anti-clockwise direction. In this case, you can also see that as soon as the cystotome completes the rhexis, and when the cystotome comes out of the eye, along with the flow of the aqueous humor, the anterior capsule also plugs the cystotome port and prevents the collapse of anterior chamber. Anterior chamber is well formed, and in presence of a very good intraocular pressure, we can make a full thickness corneal incision by the help of keratome, a diamond keratome. I am not in favor of the use of trypan blue dye to invite the corneal instaring. Sometimes happens when there is a bit delay or incomplete irrigation of the anterior chamber after putting the trypan blue inside into the anterior chamber, and there are many chances of intraocular inflammation, and the trypan blue dye also can lead to abrupt release of prostaglandin E2 from the iris stroma, resulting into the surgical meiosis. So I am not in favor of using the trypan blue dye. It's better to go for the closed chamber capsulorrhexis, and it is very advantageous that the closed chamber capsulorrhexis also gives us stable and well formed anterior chamber for the completion of full thickness corneal incision by means of a keratome. And we can also make use of a very good use of the anterior capsule as a plug to the cystotome port, which prevents the flow of aqueous humor outside into the conjunctival sac. Thank you very much.